G'day, Michael McCullough here. I'm here to talk about the innovations that have been happening in oral cancer diagnosis, and to remind you to undertake a good clinical oral examination every time that you see a patient. So you can see these graphs we've got here represent the number of cases of oral cancer that happen in Victoria. Roughly about 14 cancers are diagnosed each week in Victoria. And about a third or more of those patients die within 5 years. The 5-year survival of oral cancer is still very, very poor. And we know that by the early recognition, early detection, we can show that, that it's going to change a lot. If you look at patients who are diagnosed late, they don't survive at all very well, and the morbidity associated with that is really poor. Whereas if we can diagnose early, then that's much more likely to get 85 to 95% 5-year survival. So early recognition, early diagnosis is going to save people's lives, but also going to make a big difference to the morbidity, the quality of life as well. And the Victorian government a couple of years ago started this program called the Early Diagnosis and Prevention of Oral Cancer. And part of that program last year, we ran out a pilot study, and from learning from that pilot study, we intend to set up online learning hubs with lots of information, with lots of videos of undertaking oral examination, lots of lesion detections, and how to refer the patients, where the correct referral pathway for those patients, to help you in that early recognition of oral cancer, and also to help you talk about the causes of oral cancers with your patients. We know that if we can talk about particularly smoking, we know smoking has a direct effect to oral cancer, the development of oral cancer. But there's other things that have been shown now over the last decade, and particularly alcohol consumption. And alcohol consumption with oral cancer is a really big risk factor. And we need you to talk to your patients about those risk factors. And recently, with more people coming to Australia and more diverse population, we've noticed an increase in number of people using betel pan. And betel pan in Southeast Asia and India is directly related to the development of oral cancer. And that relationship is really, really well proven. And in our new immigrants coming to Australia, we need to make sure that those patients are also being talked about this as being a risk factor as well. Very high rates of submucous fibrosis and very high rates of oral cancer with long-term use of betel nut. We know that the human papillomavirus is associated with oropharyngeal cancer, not so much oral cancer, but it's something we should be able to talk to our patients and talk to them about things that they might notice differently that are happening in their throat. If they've noticed any change in their voice, if they've noticed any change in feeling in their mouth, any lumps that are in their throat, we need to get those patients to see their doctor and get a good examination through an ear, nose and throat specialist. But we should be able to talk to them about prevention as well and the association with HPV. Obesity and incorrect food is very also associated with oral cancer. And finally, alcohol in mouthwashes. We know that alcohol is the problem, so alcohol in mouthwashes is also long-term a problem with our patients. Part of the learning hub that we're developing is we're also going to talk about different lesions and the recognition of different things in the oral cavity so that you can see those and know when the correct time is to refer. And you don't need to refer every single patient. You can probably deal with a lot of changes in the oral mucosa yourself. But when you see things that are persisting, that are ongoing, you need to get those diagnosed correctly. So I've got an example of 4 different things there. Oral lichen planus, which is very, very common in the oral cavity, about 1% of the population. Chronic ulcers on the top right-hand side, you can see you should be able to tell an ulcer, the cause of an ulcer with a good oral examination. But if you find an ulcer is persisting, and the timeline that we have is around 2 weeks, if it's persisting for more than 2 weeks and isn't going away, and you've kind of removed the thing that you thought would be the cause of that persisting ulcer, and it's still persisting, that's when it needs a diagnosis. So the things on the bottom right-hand side, the verruca vulgaris or squamous papilloma caused by viral diseases, human papillomavirus. Now this is caused not by the human papillomavirus that is related to oropharyngeal cancer, but a different one of those families of human papillomavirus. And finally, oral cancer. Now oral cancer for the last 40, 50 years has been recognised as an older person's disease, a disease where it's predominantly male heavy smokers and heavy drinkers. And that we think is changing, particularly associated with non-smokers and non-drinkers. So I thought I'd tell you the story of this young lady who presented last Friday to the Oral Medicine Clinic. And she's 34 years old now. At the age of 32, she saw that, or she didn't actually see that, her dentist saw that in her oral cavity. On the right lateral margin of the tongue, a very faint white speckled with a little bit of erythema that was there, completely asymptomatic that she didn't know about. It was picked up really, really early and she's still alive today. She's got a third of her tongue removed, but you wouldn't be able to tell that she's had oral cancer because it was picked up so early. So it's not just the older, high-risk, heavy drinkers and heavy smokers. You need to be able to talk about risk factors, but able to do an oral examination, a mucosal examination. Every single time you see a patient, you should be doing that oral mucosal examination. And it's kind of all members of the oral health professionals who can be doing that and talking about risk factors associated with the development of oral cancer. You can do this in 3 minutes. It's really easy to do an oral mucosal examination. It takes about a minute and you should be doing it routinely all the time. And the other minute or two, think about risk factors and talk to patients about risk factors. So that we've also got very fortunate in the last month or so, got a grant to look at looking at confocal microscope for the early diagnosis or the recognition of early changes within the oral cavity, and that's being done here at the Oral Medicine Department of the Dental Hospital and of course the Melbourne Dental School. So we'll be doing that with your patients that you refer to us. We'll be trying to find out if we can come up with an alternative to a biopsy than having to do a biopsy routinely for those patients we're reviewing long term. When you're at private practice though, you should be looking at who do you refer that patient to, and you've got lots of oral and maxillofacial surgeons and oral medicine specialists out there to get the diagnosis so that we can recognise those diseases early, get them treated early for the long-term benefit of our patients. So there's a lot of innovation around oral cancer prevention and screening in Victoria, and I hope you'll be part of this as we roll this out over the next 12 months or so. Thanks.